and welcome back. I actually have a day off for a change, but I have a ton of studying left to do, so I thought I should actually be productive. God forbid, right? So I'm going to continue with the most humbling experience I've had so far in my life. That's not true. Not even close. But we're going to continue with hematology and see if I can get lucky a couple times. It's not looking good, but we'll see. I wonder if I should place bets to, not so much if I get the question right or wrong, but which one of us is going to fall asleep first. I'm probably going to bet it's you, but there's some money to be made saying it's me. Let's jump in. Alright, so we got a 50-year-old lady. Has a DVT in her right leg, blood clot. Diagnosed a bunch of weeks ago. Looks like everything's getting better. Looked like it was unprovoked. Normal colonoscopy, normal mammogram. Apparently pap smear. Didn't say it was normal, but I'm going to assume it was. She's taking anticoagulation. Looks like she's getting better. Next test to perform. So this was the first one, I'm guessing. It was only 6 weeks ago. She's going to be on blood thinners for 6 months. I don't think you need to do anything. You don't need a chest CT, abdominal CT, pelvic CT. That's not necessary. You don't need to repeat the Doppler for the blood clot. Oh my god, I got one right. Good for me. Interesting. 10% of patients with unprovoked blood clots. That I did not know. Alright, what's next? Young guy. Fever, bloody nose. Been feeling like crap for a couple weeks. Fever, chills, doesn't want to eat anything for 3 days. Today, with the nosebleed. Has a temperature, blood pressure is a little bit soft, not that bad though. Heart rate's up, respiration's up, he is sweating. He's got bleeding in a lot of places. No lymphadenopathy. No hepatosplenomegaly. He has got petechiae everywhere. There's that word again. Petechiae. 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 Alright, he's got some blood work done here. What's abnormal? PTT is prolonged. His leukocyte count is fine, but he's got lymphocytes, monocytes, and atypical cells. Platelets are crap. Prothrombin time is up. Fibrinogen is down. Interesting. Most likely diagnosis. Well, the answer choices are acute promyelocytic leukemia, aplastic anemia, chronic granulocytic leukemia, or immune thrombocytopenic purpura. This guy strikes me as having kind of a immunological response, autoimmune response, given the months of feeling like crap, for several weeks, I guess. I didn't know the answer to this one. It's APML. Let's see what it has to say. APML may present with a reduced total leukocyte count with features of DIC, disseminated intravascular coagulation. Well, that's what he's got, so I didn't know the association there. Now I do. Now I do. Okay, pancytopenia, immature leukocytes. DIC, bleeding, yeah, okay, fine. APML, acute promyelocytic leukemia, may present with a reduced total leukocyte count and features of DIC. Okay, well, young guy, DIC, APML, APL, fine. Older lady for an evaluated globulin fraction of total serum protein level. Wonderful. No symptoms. Important. High blood pressure. She's on high blood pressure and cholesterol meds. Normal physical exam. Normal everything, really. Everything's normal. But monoclonal spike, IgG, but everything else is normal. No lytic lesion, so they're trying to get me to talk about some sort of multiple myeloma or something like that. MGUS, Waldenstrom's, whatever. But I don't think you have to do anything because she has no symptoms other than maybe repeat in a few months, I guess. Yeah, that's what I thought. In patients with IgG monoclonal gammopathy of undetermined significance, an M spike of less than 1.5, the risk of progression is low. Okay, so it was 0.7. I didn't know what that number meant, but looking at her clinical picture, she seems fine, right? And there's the one lab test that was abnormal, and they did some pretty extensive workup already. In this patient with IgG MGUS, MGUS stands for monoclonal gammopathy of undetermined significance. There you have it, there it is. Alrighty, what have we here? 65-year-old lady, recurrent sinusitis. Not feeling that great for the past year. She grew H-flu in her drainage. An encapsulated organism. Okay. CT looks like chronic sinusitis. Okay. Duh. Everything else is normal. She's got stuff draining out of her nose. Great. Remarkable physical exam findings. And you poke her in the sinuses and it hurts. Alright, what's going on with her? She has no IgA, no IgM. Fabulous. She has a monoclonal spike, multiple lytic bone lesions. She has a plasma cell malignancy. Which of the following is the most appropriate immediate management to prevent recurrent infections? Well, that's a good question. She has no lymphocytes. Well, few lymphocytes, but everything else is fine. She is anemic. Her platelet counts. It's low, but it's not terrible. But I think her leukocyte count is actually normal. Yeah. immediate management. So let's see, acyclovir is an antiviral medication. It gives us H. flu, which is a bacteria. GCSF is medication that you give so that people can recover their white count numbers or all their cell line numbers. Fluconazole is an antifungal or intravenous immunoglobulin. Now, she doesn't have those globulins. If you give her GCSF, though, it's just going to give her more plasma cells that aren't functioning properly. So I don't think that's the right answer. I think you just give her IVIG and see what happens. Oops. I pressed the wrong button. Awkward. Yeah. Just critical thinking skills. And granted, 7 years of medical education on top of the couple years of research and undergrad and all that good stuff. It's a lot, I know. "50-some-year-old guy, tea-colored urine, gross. He was hospitalized 2 weeks ago with melena. Upper and lower scopes saw nothing. Got a unit of blood and was fine. He got in a car crash 5 years ago with a bunch of surgeries and doesn't take any drugs. He has a low grade temperature but not a fever. He has sclerolictris, which means the whites of his eyes are kind of yellow. His hemoglobin is dropping. His indirect bilirubin is through the roof. And he has 4+ blood, but only 2 to 3 erythrocytes or red blood cells. What is the most appropriate next step in the management of this patient? He needs blood. He's anemic. Please give him blood. They want to do a Coombs test. Really? They wanted me to see that he's having a transfusion reaction. Likely experiencing delayed hemolytic transfusion reaction. Usually occurs 7 to 14 days after transfusion. Okay. It says patients who are well compensated for their degree of anemia do not require immediate transfusion. Well, here's the... I don't think this is actually what happens on the wards, though. That's what annoys me about these questions is it's not actually how medicine is practiced, but that's fine. Whatever. Alright. We've got a lady that's a little bit younger than I am. You hate to see that in those question stems, really. Oh, gosh. 39 weeks gestation. Otherwise uncomplicated first pregnancy. Good for her. C-section because her label failed to progress. Okay. Healthy female infant. And then heavy vaginal bleeding afterwards. Placental abruption. Yikes. Blood pressure is a little bit low, heart rate is a little bit high. Respiration rate is a little bit high, moderate bleeding persists. There are some lab studies here. What do you give her? So APTT is a little bit high. PT is also a little bit high. Fibrinogen looks like it's a little bit low. What do you give her? Doesn't give me an INR. Sounds like she needs all the factors. In our hospital, the cutoff for active bleeding is 50,000 platelets. And hers is 83, so let's see what happens. Yeah, cryoprecipitate. She needs factors. Hypofibrinogenemia, secondary to DIC. Okay. One of the answer choices was cryopore plasma, and I don't know what that is, so let's see what it is. Cryopore plasma, derived from fresh frozen plasma, in which cryoprecipitate has been separated, is limited to refractory thrombotic thrombocytopenic purpura. Although an advantage over fresh frozen plasma in this disorder has not been proven. Okay. So, note to self, cryopore plasma is always the wrong answer. Good to know. Yeah, like I was talking about for 50,000. It says here, although the patient does not have, although the patient does have thrombocytopenia, platelet count exceeding 50K is generally acceptable to manage post-surgical bleeding. But it needs 100,000 if it's bleeding in the dome. Cool. 22-year-old lady. 2 days, fatigue, shortness of breath, getting worse. She has sickle cell disease, good control, rare crisis, hydroxyurea, folic acid. Heart rate's 125, that's too fast. Respiration's a little high at 25, O2 sats at 93, on ambient air, not ideal. Clear lungs. Her hemoglobin is 4. That's not enough hemoglobins. Her hemoglobin is 4. Yikes. Reticulocyte count is 0.1%. Most likely diagnosis. Oh god. Well, aplastic anemia would mean she has nothing in her, but she's got leukocytes and platelets. Parvo, I believe, means she's got nothing in her. Parvo causes aplastic, I think, or something like that. Hyperhemolysis syndrome. I didn't get any indication that she's hemolyzing. I guess it's myelodysplastic syndrome. I guess. I actually don't know. It was Parvo. Oh, Parvo preferentially affects erythrocyte precursors in the bone marrow. I guess I didn't know that. I did know that. I just forgot because it's been so long. Alright, let me read about this. Red cell, pure red cell. Oh. The patient has a parvovirus B19 infection, presenting with pure red cell aplasia. Yeah, I forgot about that one. Bummer. Well, you learn something, you know? That's the whole point of this. A 76-year-old lady. Essential thrombocythemia. Hospitalized for a stroke. Platelet count of 660,000. Yikes. Couldn't find why. She has diabetes and high cholesterol. Great. She is paralyzed on the left side and has a giant spleen. Bone marrow biopsy shows hypercellularity, an increased number of enlarged megakaryocytes. What do? You're platelet free, sir. Get rid of the platelets. No, you had hydroxyurea. I had no idea. Let's see why. Platelets with essential thrombocythemia who are older than 60 need hydroxyurea. That's not helpful. I want to know why, though. Okay, so hydroxyurea is a platelet-lowering agent. Okay. So she's already on an antiplatelet agent, but she needs a platelet-lowering agent. And apparently hydroxyurea is a platelet-lowering agent. Fun. Alright, what have we here? 28-year-old lady. Getting a physical before going to work. Feels fine. Looks like... Alright. Her white blood cell count is kind of low. Not real sure why. She takes omeprazole. That's probably why. Oh, wait, no, it's not omeprazole. It does it? Get GERD on omeprazole. Maybe it is. I don't know. Decrease neutrophils. Well, it does say she's black. There's a sentence that says she is black. I mean, whether or not that has anything to do with it, I'm not sure, but I don't think omeprazole. There's an anti-psych that starts with an O. The name is escaping me. That rarely can cause this, but not that, obviously. Cyclical neutropenia doesn't make any sense. Autoimmune neutropenia, she has no, like, I don't know, prodrome. Yeah, benign ethnic neutropenia. That's straight up test taking skills because, like, hey, this lady feels fine. Her white count's low. She's black. Apparently, that's the thing. Found on routine testing in asymptomatic black and certain other ethnic groups. Let's see. Most commonly in black patients, but there's the Sephardic Jews, West Indians, and Arabs. Interesting. Okay, well. Are they actually neutropenic? Oh, are they like... Let's see. They don't say. So sometimes you can have fewer cells, but otherwise be fine. But, I don't know. They're not gonna help me out with that because if I have questions, they don't have answers. How fun for me. Okay, let's see what else we got. 52-year-old guy. Decreased exercise tolerance and yelling of the eyes the last 3 days. That's not ideal. Diagnosed with leprosy 6 days ago. Jeez. On antibiotics. He is Haitian. He's on dapsone, rifampin, and a word that I've never seen before. Clofazimine. Okay, well. Looks like he's got G6PD deficiency. And you give him dapsone. Don't give him dapsone on G6PD deficiency. I skipped through this because this is like the one thing from all these previous things that I remember. So here's a guy who is from an endemic area where G6PD deficiency exists. He's got he shows the physical exam findings for leprosy, but he's got a very low hemoglobin, a very high reticulocyte count. And reticulocytes are red blood cell precursors, so no hemoglobin on the red blood cells because there's no red blood cells, and So you need to make them new ones, so his bone marrow knows that. Now, what's interesting is he's got bite cells on a peripheral blood smear, and the spleen chomps out part of the red cells because there are these little inclusion bodies with G6PD deficiency. Some people said, what do you do next immediately is measure the G6PD levels. No, just stop the tap zone. Don't bother it. Testing for G6PD deficiency is reliable in men who are not experiencing an acute hemolytic episode, but is less useful during an acute episode because reticulocytes produce higher levels of the enzyme, resulting in a falsely normal test result. Or you can just fix it clinically. This is kind of like somebody shows up to the emergency room with just crushing chest pain. They put the EKG leads on them and shows a classic heart attack picture. Classic. And you don't draw the blood and wait for the troponin to come back at 10. You call everybody and their mother, and you activate the cath lab, and you fix this guy's heart. Not derping around for a troponin. No, just do it. On that soapbox, I'm going to do one more question, and then I'm going to leave you guys alone. 8-year-old lady, fatigue, exertional dyspnea. History is high blood pressure. Has not been adherent to her medications. Not ideal. Blood pressure is 180/110. Great. Frail. Pallor. Hemoglobin is 9, not enough. MCV is fine. Retic count is lower than expected. She's got chronic kidney disease. TIBC is normal. Iron is normal. Ferritin is normal. She's not iron deficient. B12 is normal. I could have guessed that from her MCV. Kidneys are small. Which of the following is the most likely cause of this patient's anemia? She has an erythropoietin deficiency because her kidneys suck. Yep. Sometimes you learn stuff in residency. Oh, man. Okay. Just going to read the key point here on this question. She's got normal sized red blood cell anemia, normal cytic anemia, low reticulocyte count, normal looking red cells, kidney disease. Yeah. Normalization of the blood count is not advised. Yeah, don't fix it all the way, but just fix it enough. Okay. Well, that was fun. I tried switching a little bit between the whispers and the speaking. And if you liked it, let me know. And I'll pay less attention to exactly what I'm supposed to be doing next time. And I tried to do more of the mouth noises. So we'll see how you like those. But for now, I am tired.